My name is Heather McCurty, and today we'll be talking about managing the skin side effects of Hep C antiviral therapy. I have no financial disclosures related to the topics in this talk. The objectives of today's talk are to review the common dermatologic side effects of Hep C treatment, including the newer treatment regimens, to review the classification for severity of these side effects, and to review approaches for treatment, particularly patient-centered and education approaches. As you know, Hep C treatment has been evolving. Dual therapy is used for genotypes 2 and 3, and this includes pegylated interferon sub-Q injections weekly, plus ribavirin by mouth 800 to 1200 milligrams daily. The newer therapy is a triple therapy. This is used for genotype 1. It includes pegylated interferon subcutaneous injection weekly with ribavirin PO 800 to 1200 milligrams daily and a protease inhibitor, either telaprevir or boceprevir PO TID. It's important to know that boceprevir is on formulary at the VA, while telaprevir is not. The goal of Hep C treatment is sustained virologic response, and this is defined as an undetectable Hep C RNA 6 months after treatment completion, and this is durable. The chance of a late response after SVR is less than 1%. Achieving SVR significantly decreases the risk of liver decompensation later and death in patients with Hep C cirrhosis. Side effects are very common with Hep C treatment. In order to keep a patient on therapy, it requires lots and lots of education before starting treatment, especially about the side effects and how to manage them at home. Ongoing monitoring for side effects while on therapy is crucial, including frequent clinic visits with the nurse and the healthcare provider. This may be every 2 to 4 weeks in the beginning of therapy. Lots and lots of phone calls with the patient as needed, and there are nursing support hotlines as a supplement to your care. Today we'll talk specifically about the skin side effects. Injection site reactions from the pegylated interferon are very common. They are more notable with pegintron over Pegasus, and sometimes this is a large reaction, perhaps as large as an orange, a circular redness, but it's not usually painful or itchy. It may not arise until up to 1 to 2 weeks after the injection, and so it's important to counsel the patient on correct sub-Q technique and site rotation. Patients may certainly use ice on the area before and after injection to decrease swelling, and to use Tylenol or NSAIDs if the site is sore or tender. Other skin side effects may cause tight, dry skin. The ribavirin rash is something that we see. This may be a pruritic maculopapular rash. It may be localized to the chest, upper back, arms, legs, or may actually be widespread. Less common is a lichenoid eruption. Alopecia can occur, but it's very mild. There may also be a change in hair texture, and this is generally reversible. Skin relief, we can encourage less hot showers or to use bath oils or oatmeal in their bath. Moisturization with emollient lotions twice daily. Using mild laundry soaps, avoiding dryer sheets. We often encourage humidification of their home. Sometimes we require a topical steroid, such as 0.1% triamcinolone, to affected areas twice daily. In order to relieve itching, we recommend the use of anti-dandruff shampoo, such as Head & Shoulders, as a body wash, non-sedating antihistamines at the daytime, and perhaps sedating antihistamines at night, which may also help with the insomnia that they're having. The rash from protease inhibitor can be more frequent and much more serious. It's important to know that rash can occur with both forms of the protease inhibitor that we use at the VA, but it is more common with telaprevir, occurring in up to 1/3 of patients. It's more common than the rash that is seen with the ribavirin, which is more common than the rash that we see from interferon. Telaprevir rashes are typically eczematous and often mild or moderate and resolve upon cessation of therapy, which, as you know, is only 12 weeks. Very rarely, telaprevir is associated with Stevens-Johnson syndrome with DRESS, which is a drug rash with eosinophilia and systemic symptoms. Treatment of mild and moderate rash from telaprevir is the same: moisturization, topical steroids, and antihistamines, but very close monitoring for any rash that affects mucous membranes, usually the mouth, or becomes severe. Severe rash should not be treated with systemic steroids due to the potential drug interaction with protease inhibitor, as it can cause a significant increase in the concentration of steroids. It's important to let the patient know ahead of time, because if they have a severe rash, they may end up at their local emergency department. The advanced trial for telaprevir had genotype 1 interferon naive, and this slide shows the rash during the telaprevir and placebo phase. So the percentage of patients with rash, as you can see here, There were some patients with severe rash and a small percentage of patients that we did discontinue the drug because of rash. Serious skin reactions, including DRESS and Stevens-Johnson syndrome, were reported, and treatment must be discontinued in those instances. This is a picture of what the severe rash may look like with telaprevir. It is generalized with pruritus, may have bullae, vesicles, or ulcerations, or, as indicated before, Stevens-Johnson syndrome. In all these instances, telaprevir must be stopped. In summary, skin side effects from Hep C antiviral therapy are very common, and they usually can be managed keeping the patient on therapy. Lots of education before starting, monitoring for side effects while on therapy, and aggressive side effect management are the keys to handling these side effects. Special care must be taken to watch for severe rash that is associated with telaprevir. Thank you.